and why. No matter if you think it's peripheral, you're still gonna scan the brain. Because remember I said it could be a brainstem issue, okay? The seventh cranial nerve comes off of the brainstem, so it could be a brainstem stroke. They're very rare that will give you a complete cranial nerve 7 palsy, but it could be. So you're still gonna get an MRI of the brain to look at the brain structures to make sure that you don't have a stroke, okay? You can get blood tests. You can get lumbar punctures to look at cytology. You can also you can look for infections. All these things that you want to do. But Bell's palsy is usually transient. The less damage there is to cranial nerve 7, the faster the patient recovers. The more damage, the longer they take to recover. Bell's palsy can be recurrent. These patients, stress can exacerbate them, and they can end up just coming back in high stress episodes. So you can see this come back and forth. Okay. Any questions there?
I'm not sure if you said it, but they were saying CT of the brain.
Well, you can do a CT initially, but an MRI would be the most optimal test. One, because you're suspecting that this is probably a stroke. Yeah, you can rule out a CT to make sure that there's no blood. But in most cases, you're going to look at an MRI because that's more sensitive at looking at tissue. So you look at the MRI and see what's going on. Okay. So all diagnostic tests were essentially normal, including electrocardiogram and labs. You're going to look at your CBC. You want to look at your WBCs. You want to look at neutrophils, lymphocytes. Remember, if the patient has lymphocytosis, then you know it's some kind of viral issue. If they have neutrophilia, you know that there is probably some kind of bacterial issue, so you're going to look at those. MRI of the brain, you want to pay particular attention to the back structures of the brain because these can be brainstem. On this patient, he has vascular tortuosity, which means that he has long-standing hypertension. Usually you'll see that. Okay. Any other questions, Laura? Laura? Okay. Let me pull it down.
Sorry, I stepped away for a second.
No, that's fine.
Just getting a snack.
All right. Sorry. Okay. 67-year-old woman is brought into the ED after being struck by a car while crossing a main street. On arrival to the ED, her eyes remain closed to stimulus. She makes no verbal sound and flexes her arms towards her body with deep, painful stimulus. Her BP is 200/60. Heart rate is 55 beats per minute. Respiratory rate is 6 beats per minute. As you open her eyelids, you notice that her right pupil is 8 millimeters, non-reactive, and her left is 4 millimeters and minimally reactive. When you move the patient's head to the left, her eyes move upwards towards her eyes move up towards the right, and when you move her head to the right, her eyes moves towards the left. Okay, so that's a whole lot in that one scenario. Okay, so she makes no verbal sound. She doesn't open her eyes. There's no verbal sounds. And she flexes her arms towards her body to deep, painful stimulus. What is her GCS?
5. Decorticate posturing.
She gets 1 for verbal. She gets a 1 for eye opening, and she gets 3 for deep, painful stimulus. When on deep painful stimulus, is she or extending? She is flexing.
Yeah, flexing.
Is flexing considered decorticate or decerebrate?
Decorticate.
Decorticate.
Decorticate posturing. Okay. So decorticate to the core. Decerebrate, they're extending and pushing their legs out. Okay. So you have decorticate posturing to the core, decerebrate posturing, they're extending. Okay. Now, what does decorticate posturing mean? We said that we had a GCSE 5, and our patient is decorticate posturing. What is Okay, brainstem intact. Okay, her cerebral hemispheres are dead.
Mm-hmm.
Yes. So if you have a patient who's decorticating, that means that the cortex is probably dead, but the brainstem is probably functioning. Now, we did some brainstem testing there. And tell me, I see everybody putting it in already. Brainstem testing is, we did oculocephalic. So on doll's eye, is her doll's eye positive or negative? I see a whole lot of positives. Yes. She has positive doll's eyes. Is a positive doll's eye a good thing or a bad thing?
Bad.
Good. Yes. You see it coming out. Yes. A positive doll's eye is a good thing. You want a positive doll's eye. You do not want a negative doll's eye. If you have a negative doll's eye, that means that you do not have brainstem functioning. Okay? You can do your folkloric testing. Okay? Usually you don't do just one, you do both. So you'll do doll's eye and then you'll do folkloric. But if I do the doll's eye and her doll's eye is positive, do I necessarily have to do folkloric? Probably not. Because I already know that her brainstem is functioning just based on her doll's eyes. So if I have positive doll's eyes, I don't want to go stick cold water in her ear because that is very, very, very irritating. Now, what does our vital signs say to us? She needs neurosurgery. Come on, guys. I'm bad. Yes, true. She has a widening pulse pressure. She has bradycardia. Yes, my love. Cushing's triad. Widening pulse pressure, bradycardia, and apnea. She's like slowly breathing, or barely breathing. She's bradycardic, and she has a widening pulse pressure. What does Cushing triad indicate? That she's about to herniate. Oh, she's already herniated because some structures of her brain is herniating. If you look at her pupillary size, her right pupil is 8 millimeters. What does that mean? It means that the uncus of the temporal lobe is actually pushing down on the third cranial nerve, and it's actually stopping it. And that's why the third cranial nerve is being compressed by the uncus of the temporal lobe. Okay, so that's uncal herniation. So she already has uncal herniation. Okay, now, so we have a G6 of 5, we have decorticate posturing, and we have a positive doll's eyes. Yes, she needs some kind of intervention fast. Okay, look for a family if she can be DNR. She's only 67, guys. She had a motor vehicle accident. She probably has blood in her head. Maybe we can decompress it. Okay? Maybe we can definitely decompress it and give her a chance. Okay? We can give her mannitol. We can give her, what else can we do? We can also, yes, we can do a craniectomy. We can also do mannitol. We can do hyperventilation. Okay, hyperventilation. What does hyperventilation do? The one thing I see here is steroids. No, we won't do steroids in this case because most likely what's going on in this patient is she has cytotoxic edema. Cytotoxic versus vasogenic edema respond differently to steroids. I mean, at this point, we'll probably throw everything but the kitchen sink on her. But, if you're going to, in this case, you're probably going to do hypertonic solution. Now, when we talk about this patient, we need to decompress, decrease her intracranial pressure. How are we going to decrease her intracranial pressure before neurosurgery takes her to the OR? Is we're going to hyperventilate her. What does hyperventilating her do? Hyperventilating her will blow off CO2. Remember from your patho class, CO2 is a potent vasoconstrictor and a potent vasodilator. So high levels of CO2 will cause vasodilation. Low levels of CO2 will cause vasoconstriction. So if you're going to blow off CO2, you're going to lower the CO2 levels, which is going to cause vasoconstriction. Remember, the Monroe-Kelly doctrine says that only 3 things live in the brain: blood, CSF, and brain tissue. If one increases, one has to decrease in order to maintain homeostasis. So blowing off the CO2 will decrease the amount of blood in the vasculature in the brain, which will help to facilitate time. The 3% or the mannitol will decrease cerebral edema, which will give us time. And then she'll probably have to go to the OR, depending on what's going on. All right? Good answers, guys. So we said patient's GCS was 5. We said that this was indicative that she had brainstem function, but her cerebral hemispheres were dysfunctional. Which cranial nerve dysfunction is manifested here? Cranial nerve 3 was being compressed. What are the significance of the vital signs? Cushing's triad. Is your oculocephalic reflex positive or negative? We said it was positive. And is the patient flexor extensor posturing? And we said flexor posturing. All right. Yes, we're going to intubate the patient. We're probably going to take her to the OR. Any questions on that, guys? Well, if we're hyperventilating, probably we're going to intubate by then. Did I miss anything, Dr. Albuha?
No, it looks like they were discussing on their own, but yeah, you definitely have to intubate them, which you just said. So, and that's how we'd hyperventilate them. Correct?
Yep. Well, you can do it with the venti mask too. I mean, you can do it with the amble bag. I'm sorry. You can always amble them and hyperventilate them that way. But yeah, we're going to try and intubate them as soon as possible. All right, guys. We're getting there. We're getting there. This is case number 8. Tim is a 30-year-old man who was found on the ground next to his car after it hit a cable pole on the side of the road. Witnesses state that the man got out of his car and was able to walk a few steps after the collision, but then collapsed within a few minutes. Paramedics subsequently found the man unconscious on the side of the road. He was taken to the nearest trauma center. His vital signs: 185/92, heart rate is 63 beats per minute, temperature was 99, respiration says 12. O2 saturation was 97%. Physical exam revealed a right-sided fixed and dilated pupil.
That's your period of lucidity. You better run. He's bleeding in his brain.
Okay. Yeah. So he had a lucid interval. So we did a CT of the brain, and this is what we saw on that CT. Now, guys, remember that from your lecture, I showed you what a subdural hematoma looked like, and I showed you what an epidural hematoma looked like. One thing I want to ask you with this one, is this person bleeding into the brain parenchyma, or are they bleeding into the meninges? Remember, we have the meninges of the brain. So we have the dura, which is the outermost layer. We have the arachnoid, which is below, and then we have the pia mater. Okay. Above the dura is the epidural space. Below the dura is the subdural space. Below the arachnoid is the subarachnoid space. And, the epidural area has over in the temporal lobe region has the middle meningeal artery that goes up into the epidural space and provides arterial blood flow in that area. So the middle meningeal artery is what's in the epidural space. In your subdural space, you have, hold on one second, my computer's about to die. That wouldn't be good. Okay, so in the subdural space, you have bridging cortical veins. And you have the venous sinuses, which are venous flow from the brain. So that's how the venous blood gets from the brain back into the heart, okay, through the venous sinuses. So in your epidural space, you have the meningeal artery. Subdural space, you have the bridging cortical veins, okay? Those are very important. In the subarachnoid space, you have the arachnoid villi. These are good, important structures that I want you to remember when we're talking about bleeding into the brain. This bleed right here is a convex type bleed. And judging from the appearance of how this patient was, this is likely an epidural hematoma. And the key to discerning that is that lucid interval that he had. He crashed, he was able to get up. He might have lost consciousness initially, then he was able to get up, walk a little bit, was awake when the witnesses saw him, and then completely out by the time the paramedics get there. Remember that an epidural hematoma is an arterial bleed. There's a rapid collection of blood in the epidural space that shifts the brain structures, and initially the brain is able to accommodate that. So that's where they have that lucid interval. Brain says, let me move over a little bit, move over here, and just make space for this blood. But then it starts coming in at such a rapid state that the brain can't move over anymore. Because remember, the skull is a fixed box. The brain can't move over anymore. What usually happens is that you end up with brainstem herniation. Okay? So this is an epidural hematoma. This is a convex shape. Look at this, it's convex. If it was a subdural hematoma, they look a little bit more sickle. So it looks more like an S. So it'll go like this. You see it like this, and it's more. Subdural hematomas are more slow bleeds. So usually patients look a lot better. They don't rapidly decline. If they're younger and they have a large subdural bleed, yes, they can rapidly decline. But older patients can actually accommodate blood in their brain for a while before you see them start being symptomatic. Sometimes when you see an elderly person with a subdural hematoma, you look at them and you're looking at their scan and you're going, something doesn't fit here. That's because as we age, our brain shrinks. And what usually happens with those bridging cortical veins, remember the dura gets stick to the skull. And then those bridging cortical veins, they get taut. So that's why some older people, they come in with this subdural hematoma and they go, well, I didn't hit my head, I didn't fall. But just a little jawing of the head can actually tear those bridging cortical veins and they end up with the subdural hematoma, okay? In this case, this guy has this lucid interval. You have this CT here that gives you this convex shape. It's usually over the temporal lobe that you see this, and this is an epidural hematoma, okay? Epidural hematomas are dangerous. They need to be dealt with emergently, or patients do really bad. Okay? So any questions, guys?
No questions that I see.
Okay.
Oh, someone asked for treatment.
Treatment will be surgery. They'll have to have a craniotomy and evacuation of that subdural hematoma, that epidural hematoma. That's the only treatment. Okay. Small epidural hematomas we tend to leave because remember the body takes care of blood when it's in a cavity where it's not supposed to be. The body does take care of it, but epidural hematomas that cause brainstem compression or cause brain compression, they have to be evacuated. There's no other way to deal with them. So surgery is going to be indicated. Okay? So my questions for you was, is this an intracerebral or extracerebral bleed? Intracerebral means in the brain parenchyma. Extracerebral means outside of the brain parenchyma, but in the skull. His bleed was in his meninges, so it's not intracerebral, it's an extracerebral brain bleed. Okay. What type of bleed is this? Is it venous arterial? We said it was arterial. What does a fixed dilated pupil mean? It means that this patient has some uncus herniation. That means the cranial nerve number 3 cannot innervate the pupil and it cannot cause the pupil constriction. So it's being compressed. And how would you treat this patient? Of course, you need a stat neurosurgery consult. All right. I want to make sure that this thing is still recording because the recording was in my way. Okay.
I'll be there. I'm in class. I'll be there.
Hold on 1 second, guys. Just hit the recording thing, and I want to make sure that it's still recording. Laura, can you tell if it's still recording?
It looks like it is.
Okay, good. All right. 29-year-old male brought to the emergency department after a head-on collision with another car. The patient was not wearing a seatbelt. Upon presentation, his blood pressure is 135/65, heart rate is 112 beats per minute, respiratory rate is 18 beats per minute, oxygen saturation is 100% on mask. His eyes are closed, but opens to speech. He can move his arms and legs on command. When you ask him a question, he's disoriented but able to converse. What is his GCS score?
I'm getting 12.
Okay, why 12?
Wouldn't it be 13?
It would be. Because he only loses 1 point for confusion. Okay? He follows commands readily, and the only thing he loses he opens his eyes spontaneously. He should be a 13. Okay.
Well, what that? There wasn't a theory that
Eso.
All right. Laura, anything there? Laura?
No, nothing. Everything's good.
Okay, good. Sandra is a 59-year-old woman with a past medical history of hypertension, hypercholesterolemia, diabetes type 1, alcohol abuse, is brought to the emergency room by her daughter, who states that her mom has been acting funny, open quotations, close quotations, over the past hour. She states that the patient did not know where she was despite being in her own house. She also did not recognize her family and was speaking incomprehensibly. Her blood pressure is 150/80, heart rate is 90 beats per minute, temperature is 98.9, her respiratory rate is 16 beats per minute. On physical examination, she is diaphoretic, agitated, tremulous. Echocardiogram is sinus rhythm. With normal ST segment in T waves, which of the following is the most appropriate course of action for this patient and why?
A lot of people are putting in check her blood sugar.
Okay, why?
Because hypoglycemia can mimic
Guys.
stroke.
It is the exact answer. The blood finger stick is first. You're going to do that anyways before you take it to the CT scanner, because the only thing that can prevent you from giving a patient TPA is not having a blood glucose. Every patient that's a candidate for TPA has to have a finger stick first. So in these kind of cases, you need to make sure that you assess the blood glucose. Really good. I've caught a lot of students on that one, so good job, guys. All right. 54-year-old man is brought to the ED by his wife for bizarre behavior. The wife complains that her husband has not been acting like his usual self over the last several days. He's been crying inappropriately for the past 2 weeks, and over the past month, he's gone from being a model employee to not showing up for work, not turning in his reports, not going to the gym, and worst of all, he has not showered or changed his clothes in the past 3 days. She recalls that her husband complained of morning headaches for the past 2 months. The patient is otherwise in good health and does not take any medications. His BP is 135/87, heart rate is 76 beats per minute, temperature is 98.9, respiratory rate is 14. His examination is otherwise unremarkable. So, based on the presentation, which part of the brain is being affected, guys?
Frontal. The frontal lobe.
It definitely would be the frontal lobe. Remember, frontal lobe is learned social behavior. It is mood and affect, all housed in the frontal lobe. Okay, all your executive function, what you think is appropriate and what you don't think is appropriate, is all housed in the frontal lobe. So, definitely the frontal lobe. How would you work this patient up?
MRI.
You definitely do MRI. You can do CT of the brain and do that.
Well, the headaches might be a bleed, but if it's been on for a while, it might be a tumor also.
It might be. However, you're going to do the CT first, plain, rule that out, or you can actually go straight to the MRI. Okay. How would you work this patient? What is the significance of the headache occurring in the morning?
Would it have to do with the position of laying down in bed?
Yes, but why?
Sleep apnea, lack of oxygen?
No, not sleep apnea, but yes, increased intracranial pressure. When you're in a supine position, your brain contents can actually, the CSF is not flowing down. So you have more CSF, more blood. So you end up with more intracranial contents. When you're in an upright position, you can actually have gravity helping a little bit. So laying in a supine position, people who have morning headaches, you should be suspicious for increased intracranial pressure. Usually what happens is they're laying flat, everything is like stable at night, and in the morning they get up, they have this really bad headache. As they go through the day, the headache gets a little bit better, okay? But morning headaches, you should always be questioning for increased intracranial pressure. Any questions on that, guys? Nope. Nothing, Laura?
Someone just asked, is that why patients are at a 30-degree angle in the hospital?
Yes, it is. We always put the head of bed on a patient who comes in with a stroke, any patient who comes in with cerebral edema, any patient who comes in with an intracranial bleed. If you see, when I go to the emergency room, they have the patient flat for intubating. The first thing I do is I raise the head of the bed. Okay, you always raise the head of the bed. You want them at a 30 angle, facilitate flow, stop the flow of blood to decrease intracranial pressure. All right, case number 12. 25-year-old female with complaints of weakness in bilateral lower extremities has been gradual over the past 5 days. She denies any medical history. She reports has not traveled outside of the country in her life, denies smoking, alcohol, occasionally. She does admit to having the flu about 2.5 weeks ago. These are her vital signs: temperature 98.4, heart rate 78, respiratory rate 18, blood pressure is 105/45. And look at her labs. Hemoglobin is 13.1, hematocrit 38, WBC is 10, platelet count is 300. The neurologist does a lumbar puncture and it shows elevated protein and normal white blood cell count in CSF. Now, when we're looking at CSF, it's very important because this is another diagnostic feature that is very important when you're dealing with brain patients. You want to evaluate CSF. When you're evaluating CSF, you're looking for white blood cell count. If it's elevated, you want to look at red blood cells. If you see red blood cells, it could be a traumatic tap. So you want to look at that. And if you see red blood cells and you're suspecting a traumatic tap, you're going to ask the lab to spin it down, especially if you're looking for something like a subarachnoid hemorrhage. You're going to ask the lab to spin it down, and you're going to be looking for something called xanthochromia. Xanthochromia is a spin down, it's a byproduct of blood that occurs in patients who've had subarachnoid hemorrhages. So someone comes in and they're complaining of the worst headache of their life, and you do a CT scan and you don't see any blood. You don't say, well, okay, you don't have an aneurysm, you don't have a subarachnoid hemorrhage, I'm send you home. The appropriate thing to do in that patient is to do a lumbar puncture and look for what we call xanthochromia. And that's the byproduct of blood breakdown that's going to occur. And remember, sometimes patients have a small bleed in the brain. They don't come to the ER right away, but then that headache doesn't go away in 2-3 days. You scan them, you don't see the blood because the body already took care of it, but the CSF will still have that blood. And when you spin it down, you'll have xanthochromia. And next thing you want to look for in the CSF, we want to look at white blood cells. We want to look at red blood cells. We want to look for xanthochromia. We want to look at protein. Protein will tell us if there is any protein should be like 0. So if you have elevated protein, it could be infectious. It could be inflammatory.